Hi everyone, welcome to today's MDS Open Office Hours. If you have questions for Jennifer, please type it in the Q&A section. If you would like to talk, please click on raise hand and we can move you to panelists. Jennifer, please start. Thank you.
Well, good afternoon, good morning, hello. I want to thank everybody for joining us for the open office hours. It's the first time I've kind of done an open office hour, so I'm excited to answer any questions that you may have. Some folks have already sent me some questions and I did respond via email to some, but I did want to bring them to the group's attention because sometimes if other people have a question and they don't realize they have that question, it's good to share with everybody to make sure we're all on the same page. So one of the questions that came up since our last session, and this is open to any types of things, not just the stuff that we discussed last time, there was a question about the delirium CA and who really should be completing that. And that's kind of a tricky question because the delirium CA can be triggered many ways, and most of the time it's triggered by something that the social worker might do in their interview or in their section that they're completing on the MDS. But delirium certainly has a lot of clinical considerations when doing the care area assessment. So although it might be the social worker section that actually triggered the delirium, I really think it should be a joint effort between nursing and the social worker. Maybe the social worker could speak to why did it trigger, what did they see related to that trigger during their interviews or in their assessment, and the psychosocial factors that may be associated with a potential delirium. But then it needs to also be addressed by the nurse, because certainly there are clinical indicators that the social worker is not going to have. That's not their background. They're not going to know about the infections or the lab work or any of those other items that might be popping up depending on how you do your cause. I personally just like to use Appendix C of the REI manual to do those cause, just to make sure that I haven't missed anything. So kind of as my checklist, a lot of softwares use the Appendix C also as their checklist. And running down those items, there's a lot of things in there that are really not something that the social worker is going to have knowledge about. So the nurse really needs to put his or her 2 cents in about all of those clinical indicators to show, is this truly a problem? Is this really a delirium? Is there something that we need to take care of? Because this could be a rapid onset. I mean, if there's something going on with an abnormal lab, or maybe there was a med error, or maybe there's an infection, we need to act on that pretty fast. And that's something that's going to be a clinical call. So although, like I said, it's a social work, a lot of times social work might trigger it, I do recommend that nursing have a big piece in the completion of the delirium CA. And I had that as a couple of folks asked that question. I think they were from the same facility. Another question that popped up in my emails, somebody had asked about section M 1040D. So this is our skin section asking about other lesions and what does that mean as far as what we should be coding. So the example on the form and the example in the REI manual are actually different. One says bullous pemphigoid, the other one says cancer lesions. They actually are intended to be both the same kind of thing. So what we're looking at in this section is something that is related to something that happened with a clinical disease or condition like syphilis or cancer, bullous pemphigus, not an injury. So any trauma wounds would not be counted here. The weird thing about MDS is it's a minimum data set. Yeah, it's like pushing 50 pages now, but it is still a minimum data set. So we would not put any of those traumatic lesions or cuts, rashes, abrasions. Those don't get coded under open lesions. Anything that's traumatic. And if there's not a spot for it in section M, there may not be a spot to code it on the MDS. What you could do is, if you had a diagnosis code in place to support that traumatic wound, you could have that in section I, but it is truly a minimum data set. Not every single possible thing that could be coded on the MDS is going to have a space to code on the MDS. So we don't want to try and carve it into somewhere else if it doesn't belong there. Pressure ulcers, pressure injuries, venous arterial ulcers, diabetic foot ulcers, or skin tears, those do not get coded here either. They have their own spots on the MDS of where that should be coded. So basically we're just looking at, for those other lesions, anything that develops as a result of a disease or condition. That can be found on in the REI manual. M-29 is the page for the reference for that. So thank you for that question. A lot of these questions are very common questions I've seen a lot over the years. Another question that came through was asking if we could discuss the quality indicators that are driven by MDS and the ones that play into the star rating. That's actually going to be part of our webinar next month. So tune in next month and I will give you all the dirt associated with the quality measures and the 5-star rating. That will be our introduction piece, and then we'll dive a little deeper with the following webinar, the next full session that we would have. So thank you for that question. Another question that came in, kind of a multi-part, some things that are of concern to this particular coordinator is, when do I do a significant change? So I don't know how many of you are alum of MDS 2.0. Under MDS 2.0, the manual was a little more clear as to, if you code this on this assessment and you code that on the next assessment, it's a sig change. They've given us a little bit of guidance in the REI manual, but nothing that's definitive. It's basically what the government has told us is you need to use your clinical judgment, and you need to be able to figure out, is this resident's change significant enough that you need to look at that plan of care and get the entire team involved and make sure that what you're capturing is accurately reflecting this resident's current. I always like to say it's establishing a new baseline. A significant change in status is establishing that new baseline for that resident. And there are some little bit of guidance given in the REI manual in chapter 2, but that's just it. It's just a guide. It's not intended to be an end-all be-all of things, but there are some things that you do need to be mindful of. It needs to be 2 areas or more of a major decline or improvement. It needs to be something that will not normally resolve itself without any intervention by staff or implementing standard disease-related clinical interventions. So it's not self-limiting. So if they have a UTI, or they have the flu, or they have something that is hopefully a transient condition, and we're expecting that they're going to return to their normal function baseline, whether it be ADLs, whether it be skin, whether it be behaviors, mood, cognition, any of that. If we're anticipating that they're going to go back to baseline after this acute transient condition has resolved, then you don't need to do a significant change. Certainly you need to have a care plan in place. Certainly you need to address that in the medical record. The medical record needs to tell the story. But you don't necessarily have to address that as a full significant change. It also needs to impact more than one area of the resident's health status, and it must require interdisciplinary review or revision of the care plan. So there is some guidance starting on page 2-22 of the REI manual that tells us, when it might be appropriate. But there's also situations where it's not appropriate. So if you have somebody who is improving, steadily improving, they're on rehab, they've made a lot of gains, they're doing really well, you don't have to keep doing a significant change in status as they improve in their ADLs or as they improve in their condition. We're treating them for an acute condition, they're maybe in our facility for skilled time, or there's something acutely going on, they're getting therapy services. You don't have to, as they're progressing, you don't have to keep doing sig changes. Once, say, the therapy has ended, they've graduated or they've plateaued, then you'd want to look to see, gee, have they significantly improved? And this is actually an area that I have seen kind of missed a lot because they don't think about the significant improvement, or especially back prior to PDPM, we had a lot of assessments in between back in the old days, 5, 14, 30, 60, 90-day assessment. As we're doing all these assessments, they made gradual improvements. And then once we got to that final assessment, oh, well, they haven't really had a big change because on their last assessment, they were this. We might see this more now in that we're only doing a 5-day for our Medicare folks, or maybe, an interim payment assessment for those folks. What we have to compare it to is, so they've graduated off of rehab, they're going to stay in your facility for a while. We need to now look at them and have they changed significantly from that admission assessment, not from the IPA, but from that admission assessment. That's what the comparison is to. The comparison is to the previous OBRA assessment, not to the previous PPS assessment. So we need to make sure that we're looking at the right thing and that we're comparing the correct assessment. And then we want to see, all right, well, have they improved? ADLs is an area that you can improve in 2 areas, and that's enough to put you into a significant change of status. If they've had an improvement and they're now newly coded as independent supervision limited assist, that could be enough to do a significant change. My rule of thumb is, if you're questioning if a significant change should be done, I would do it, because I would rather have more information, more assessment, and more care plan on that resident than not enough. So that's always my rule of thumb. But certainly, taking a look at the guidance in the REI manual is helpful. So really making sure that you understand that, that you're not doing too many. We don't need to do an assessment every week as they're improving with their ADLs. And for that matter, if somebody's declining. So if you have somebody who is maybe terminal, certainly we know that we have to do a significant change. It's required if they go on to hospice services, if they have a new hospice provider, or if they graduate from hospice services. That's a requirement regardless of when we did the last assessment, what we coded on the last assessment, that's a requirement. But if, let's say, we just do a significant change to say, okay, they're end of life, they're not hospice, you can care plan to say that further decline is expected related to this terminal condition. And you don't have to keep doing significant changes as they decline because it's expected. You've care planned this, we know that they're declining. Now, if they have something that's way different from what that initial terminal care plan was about, they fall, they fracture, then certainly that is not necessarily related to that terminal condition and was not an expected decline. So I would do a sig change at that point as well. There's really a lot with the significant change, and it's really just knowing the baseline of what's in the REI manual and then applying that and saying to yourself and your team, does this MDS accurately reflect what this person's current status is? And is this different from the last OBRA assessment? Another piece to this puzzle, I could probably spend the whole time talking about sig changes, is when do I establish that there is a new baseline? So what you have to look at is this condition or this change something that's going to last more than 14 days? So when we talked about it's not self-limiting, it's, you know, transient. But if it lasts more than 14 days, this is now kind of their new baseline. So we first have to establish, is this change going to last 14 days? So if you're in your morning meeting or your clinical meeting and the director of nurses says, oh, we've had a clinical change. Okay. That does not mean that you have to immediately throw a significant change of status assessment in. You first need to establish for 14 days, give a 2-week review and say, okay, they've had a change. Let's look at them for a couple of weeks and see if they go back to baseline. Now, at the end of that observation period that you're just doing kind of internally as the MDS coordinator, and you realize, you know, it's been a couple of weeks, they still haven't gone back to what that previous MDS status was. So now we're going to decide to do a significant change in status. The instructions is that you should be writing a note in your clinical record at that point to say, we have decided they meet the criteria for a significant change in status. You then, from that point, have 14 days to complete your significant change in status. So usually, personally, what I do, once I've determined they're a sig change, I will do a 7-day window. That'll be my look back, my ARD for my significant change, to give all of my team enough time to do their documentation, their assessments, their observations, their interviews. And then I have another 7 days to complete it. So that, and then you have another 14 days after that to submit it once everything's done. You have 7 days to complete your, you have up until that completion date to complete your MDS and your cause, another 7 days to do your care plan, and another 14 days to submit it. So by the time you have realized there's a change, and then by the time you determine it's actually a significant change that requires an assessment, it could be a month and a half from when the change was initially noted. And that's perfectly okay. As long as your documentation shows, okay, we've done our review, we've seen that there's a change, we've documented, we now have established that there's a significant change, and then that's where our time frame comes from. So there's a lot of work and parts with the SIG change. So I appreciate that question. It's kind of a heated, loaded question, but I appreciate the opportunity to chat about that. And certainly, I'm always up for a nice discussion with anybody if they want to shoot me, hey, I have this scenario, what do you think? And then kind of working it out. Sometimes it's good to have a couple of heads. Another question, let's see. Oh, I see something about COVID. Seems like that would be a significant change, but maybe. I guess it would depend on that particular person's response to being COVID positive. If we determine they're COVID positive, they're symptomatic, they're having changes, and if they're still on the downswing 14 days later, then yeah, I would maybe say a significant change would be appropriate for somebody with COVID. Yeah, it all depends on that status, whether they've got the symptoms, whether it's actually changed them. I have had so many people in nursing homes in my area who completely asymptomatic and are testing positive for COVID like continuously, and no clue that they even had it. There was nothing wrong with them. There was no issues, no respiratory problems, nothing, no fever, no stomach, nothing. So it really is going to be an individual assessment on that. Let's see, another question that had come in prior. Modifications. So it's kind of a tricky piece to know if you're doing them correctly. So yeah, I certainly can see how modifications could be tricky. Basically, what we have to look at is, what is the status of the resident at the time of the assessment reference date? And did that accurately reflect what was true and going on with that resident and documented in that time period? So there's a scenario that this person asked about. So they had a person with an ulcer, pressure ulcer on a foot a year ago, coded as such on the MDS. And then they went out to the hospital, and the doctors in the hospital decided this was never a pressure ulcer and is now a neuropathic ulcer. So what do we do with this? Well, the documentation you had in place at the time of the ARD supports the pressure ulcer. So I wouldn't do any modifications at this point. I would go moving forward with the documentation that's in place, and then make sure your chart tells the story as to why you changed it, what you did, what the issue is. Make sure the care plan is tight and the documentation is tight. But I wouldn't go back and change the MDS because the documentation you had at the time supported the pressure ulcer. I can definitely see why that was a tricky question. And certainly if we have further questions on that, you can certainly contact me, and we can chat a little bit more about that particular issue. So I see some questions coming on the chat. Should all residents be attempted to be interviewed each time versus going to staff interview? Oh, what a wonderful loaded heated question. Yes, yes, yes. Absolutely. The instructions in the REI manual is that everybody should be offered and attempted to be interviewed. Even if you think you know that they're not going to answer, that they're not interviewable, the instruction is you still have to ask. You still have to attempt the interview. So a piece of this that you have to understand is whoever's doing those interviews has to have a good understanding of what is the definition of rarely or never understood. So B700, make self understood, is related to those gateway questions in the interviews. However, B700 is completed after the interviews are done, because the interviews have to be completed on or before the ARD. So you can't do your interviews after the ARD when B700 would have been answered. So whoever's doing the interview and answering those gateway questions has to understand what B700 means. So make self understood, the ability to express or communicate requests, needs, opinions, or to conduct social conversation in his or her primary language, speech, writing, sign language, gestures, combination. We have to look at the resident as a whole, not just, well, I'm the social worker and I'm going to go see them and they never talk to me. So they're rarely or never understood to me because they never talk to me. But if you have a resident who doesn't feel comfortable with you because you don't see them that often, or maybe they have a primary care aide that they see all the time, and maybe they talk to them. I have a perfect scenario of this. This was pre-MDS 3.0, so we didn't do the scripted interviews, but I always talked to the residents anyways. So I was going to talk to the resident. I knew this resident was nonverbal. I'd been there 5 years. I'd never heard the woman speak a word. So I was going to talk to the CNA. So the CNA, primary CNA, was in caring for this woman, and I was waiting outside for the CNA, and I could hear the CNA talking to somebody. And so she comes out. I said, "Oh, who was in there with you?" Oh, she said, "Oh, Mrs. Q and I were having a conversation." I'm like, "What? I've never heard this woman speak before." She's been seeing this woman as her primary caregiver every day, sometimes double shifts, sometimes 6 days a week, for years. She felt comfortable with her. She knew her. So if we were doing interviews at that time, I would have trained the CNA how to do the interview, and at least maybe she could have gotten a little bit more out of that resident, and we attempted the interview, then we may still have needed to go to the staff assessment because maybe she didn't answer all of the questions to make it a complete interview, but at least we've heard the resident's voice. So absolutely, we want to make sure that we're attempting the interview and not just writing them off as being unable to be interviewed. We've got to follow that guidance from the REI manual, so we are capturing the resident's voice, even if it doesn't match what we think it should be because the medical record says something different. We always have to start with the resident's voice and attempt those interviews with them. And yes, there definitely is a lot of misunderstanding about that, to follow up on that question. Another question that has come in. Had a resident fall on 3/17, sent to the hospital immediately, admitted and had a fractured hip repair, re-entry on 3/23, A1600. Question is, how should we have coded J1700 and J1800 on the significant change MDS with the ARD of 330? Okay, so that discharge assessment on 3/17 you should have coded that hip fracture and the fall with major injury on that assessment. Because when you now have your significant change on 330, this is going to be coded as your first assessment. So then it's going to open J1700. J1700, you're going to capture that fall with the fracture. However, J1700 does not affect your quality measures. Only J1800 and J1900 do. So J1700, although you've captured the fall with the fracture, unless you've captured it on the discharge MDS on 317 in J1800, you're not going to be calculating your quality measures correctly. So you would say on the 330 assessment, J1700, they have had a fall within the month with a fracture related to it. And then J1800, we're only looking back to the date of entry. So if they did not have a fall from 323 to 330, J1800 is going to be no. There's going to be no falls. So you wouldn't be picking it up there. Hopefully that answered your question. Another item in the chat, please discuss the rationale reasoning for the difference of QM definition of need for help with ADLs is increased and the ability to move independently has worsened, and the MDS definition of significant change. Okay, we've got a couple of different things in there. So the need for help with ADLs has increased. That is looking at the 4 late loss ADLs. So bed mobility, transfer, toileting, and eating. And then the ability to move independently has worsened is looking at locomotion on unit. So we're looking at some different ADL pieces. The late loss ADLs, these are the things that you're going to, they were the first things you learned as babies, the last thing that you're going to lose as you decline as an adult. And it's just, they're looking at 2 different aspects of the ADLs. One looking at those 4 late loss, the other one's looking at their ability to move either in their room or in a corridor on their own unit, whether in a wheelchair or walking. How are they able to get from point A to point B on the unit? One thing that I have found is this triggers quite easily because folks are not looking at the resident and asking all the staff all of the possible things that may have happened in that full 7-day window. So it's a 7-day look back. You're looking at every episode that has occurred with locomotion on unit. Locomotion on unit is 2 pieces, in their room and in the corridor. It looks at every single episode. So although the resident may be able to walk around in their room, and maybe they're independent with wheelchair mobility on the unit, we have to ask the staff and the resident, have they ever been pushed in the wheelchair? Oh, let me just bring you down to the, oh, let me just bring you. And the staff is just, you know, helping out. Let's help this resident get down to the other end of the hall, or go somewhere. Oh, I'll help bring you to the bathroom. Oh, it's time to, I'm on my way, I'll bring you with me. Every time a staff member pushes a resident in the wheelchair, they're providing total care for that episode of that locomotion. If that happens 3 times, but not every time in that 7-day period, that's an extensive assist. So if we're not accurately capturing those extensive assists, even though they may not physically need it all the time, if it happens 3 times in that 7-day window, we're supposed to code that. So when we don't capture it on that initial assessment, then once they maybe decline a little bit more, or something happens, or COVID hits and they're stuck in their room, so they're not out in the hallway and they're not moving around as much, now it's going to show that it's a decline because they're now coding them as an extensive assist, or even a limited assist, because it's just a decline in 1 point. So they could go from an independent to supervision, that's going to be a decline. They could go from a supervision to a limited assist. That's a decline. It's a very quick, easy way to trigger. The ability to move independently has worsened. It's not as quick and easy to trigger a decline with the 4 late loss ADLs. It either needs to be a 1-point decline in 2 areas or a 2-point decline in 1 area. So if they were independent with bed mobility and now on this assessment, they're limited assist, that's a 2-point decline because a 0 is independent and a 2 is limited assist. So that went down 2 points. Or if they were independent with bed mobility and transfer and now they're supervision with bed mobility and transfer, that's also a decline because it's a 1-point decline in 2 areas. I'm not quite sure what the last part of that question is asking and the MDS definition of sig change. I thought we had already talked about that, but certainly if there is further question about some sig change stuff, you can absolutely email me about that. So it looks like our time rapidly came up. I want to thank everybody for joining, and my email is jennifer@triadhc.net if we have any further questions in between. And our next meeting will be next month on the quality measures. So thank you for having me.
Nice job, Jennifer. Thank you so much. You did a great job responding.
Thank you.